Good morning, everyone. I'm Dr. Prajwala from our Global Hospitals. Today, I would like to discuss regarding the basic vital monitorings and a few of the bedside tests that are given in the ICU by the ICU nurses. So, ICUs are vital for enhancing the survival of the critically ill patients through the continuous monitoring and maintenance of their vital functions. The early recognition of the patient deterioration and timely interventions are critical in saving the patient's lives. Subtle changes in the vital signs and early signs of clinical deterioration that may eventually lead to adverse events. And vital monitoring clinical deterioration can be, with this clinical deterioration can be identified well in advance of any adverse events occurring. Coming to the vital signs, according to the NICE guidelines, it recommends the basic vitals like heart rate, respiratory rate, blood pressure, saturations, levels of consciousness, and temperature. Along with it, there are additional monitorings of pain and urine output and biochemical analysis are also being added. Coming to the pulse, the first vital, the pulse. It is defined as the palpable rhythmic expansion of an artery produced by the increased volume of the blood pushed into the vessels by the contraction and relaxation of the heart. It reflects both the circulating volume and the strength of the contractility. Factors that can impact the pulse of the patients include the age, the medications, existing medical conditions, pain, and fluid status. Pulse incorporates not only the heart rate, but more than the heart rate, measuring of the heart rate, which is measured. Heart rate is a measurable characteristics of the pulse. When we while palpating the pulse, the strength, the amplitude of the pulse, the regularity of the pulse, and the peripheral equity of the pulse should also be considered. Many of the characteristics of the pulses are monitored using an ECG, which is essential in the diagnosing cardiac rhythm disorders because the incidence of the cardiac arrhythmias are as high as 40% in patients in the ICU, and they can attribute to the electrolyte imbalances, metabolic disturbances, invasive lines, multiple drug therapies, quick changes in their intravascular volumes. So heart rate, which is a component of the pulse, it is reflected by number of QRS complexes per minute. The normal range is from 60 to 100. Tachycardia is considered when it is more than 100. Bradycardia when it is less than 60. The next component would be the blood pressure. It is the pressure of the circulating blood against the walls of the arteries. The parameters, it generally includes three components, that is systolic, diastolic, and a mean arterial pressure, which is a calculated component. The systolic blood pressure, the normal range is from 90 to 140. Diastolic, it is from 60 to 90 mm of Hg, and the mean arterial pressure is 70 to 105. Any alterations in blood pressure can be reflective of the underlying pathologies or the body's attempt to maintain the homeostasis. There are many factors that influence the blood pressure, which includes the cardiac output, peripheral vascular resistance, blood volume, viscosity, as well as the vessel wall elasticity. Few other factors that influence are like nicotine, pain, position of the patient, medications, alcohol, and illicit drugs. Blood pressure can be measured both invasively and non-invasively. Non-invasively by sphygmomanometer, invasively using an arterial line placement into the femoral or radial artery. The next component is the respiratory rate. It is the number of breaths taken per minute. A rise in the respiratory rate is the most sensitive indicator of the clinical deterioration and impending adverse events. While the measurement of the respiratory rate, it is important to assess the pattern of the respiration also. The important, we have to assess the respiratory effort, chest movement, pattern or rhythm of the breathing, the inability to breathe spontaneously. So there are the terminologies which include different criteria. There are tachypnea, abnormal, which is an abnormal or quick heart rate, a respiratory rate that is more than 20 per minute. Bradypnea, it indicates the respiratory rate of less than 12 per minute. Dyspnea, difficulty with breathing. Orthopnea, which means the difficulty in breathing and that necessitates an upright sitting position. Hypoxia, which means the insufficient oxygen at a cellular level. Hypoxemia, low levels of oxygen in the blood. And anoxia, which means lack of oxygen. The next component of the vitals are the oxygen saturations. It is the ratio between the oxygenated hemoglobin and the total amount of the hemoglobin in the blood is expressed as SpO2. The pulse oximetry is the technique used to measure the arterial oxygenation saturations in the peripheral blood vessel, which depletes as SpO2. The normal SpO2 is from 95 to 100%. The SpO2 which is less than 90% is of a concern, and because as the fall of SpO2 indicates the development of hypoxemia long before any visual evidence of cyanosis is present. There are various factors that influence the pulse oximetry and the recordings. There are the movement of the patient, incorrect positioning of the probe, hypothermia, hypovolemia, vasoconstriction, and nail polish. The fourth vital would be the temperature. The body temperature is represented by the balance between the heat produced and the heat lost. Clinically, three types of blood pressure body temperature have been described. That is the patient's core body temperature, patient's report on how they feel, or the surface body temperature, how the patient feels to touch. The factors that affects the temperature are the underlying pathophysiologies, like any underlying pathophysiological infections, diseases, sepsis, and all those. Skin exposure, for example, when the patient is exposed to high or low temperatures, so temperature fluctuations, age, site, and local factors. It is therefore important to consider not only proper calibration of the measuring devices, but also the variation of the core temperature between different anatomical sites. Documentation of the site of the measurement along with the measured temperature is essential for the accuracy of the measurement. Core thermometers are more appropriate and preferred in critically ill patients rather than peripheral thermometers. Core thermometers, these are the located on catheters and probes which are inserted into pulmonary arteries, esophagus, nasal cavity, bladder and rectum, and the peripheral ones are the ones which we measure oral, axillary, tympanic membrane regions. The normal temperature would range from 36.8 degrees centigrade with plus or minus of 0.4 degrees centigrade, which is measured in the oral cavity, and with a normal circadian variation of 0.5 degrees centigrade. Mild hypothermia, it is considered when the temperature is from 33 to 36 degrees centigrade. Moderate hypothermia is considered 28 to 32 degrees centigrade, and the deep hypothermia below 28 degrees centigrade. Fever or hypothermia, it's in temperature above 38.3 degrees centigrade is indicative of fever or hypothermia. The next vital is the level of consciousness. Level of consciousness, it is the single most important indicator of the cerebral function. It can be defined as the degree of arousal and wakeness of the patient. In the critically ill patient, the LOC is most commonly assessed using the GCS scale, the Glasgow Coma scale. But a simpler AVPU neural assessment method can also be used. So the GCS score less than 12 is considered concerning, and a patient with a score of less than 9 will probably require an airway intervention or intubation. Reduction of 2 points on a GCS is considered significant and indicating a clinical deterioration in the patient. GCS consists of three components, EVM, which can be remembered with a mnemonic of EVM. Three components are eye opening to response, best verbal response, and best motor response. Eye opening consists of four components, that is which opens eye spontaneously to speech, to pain, no response. Best verbal responses that could be oriented to time, place, and person. Confused, inappropriate words, incomprehensible sounds, and no response. Motor response is from obeys commands, moves to localized pain, flexion, withdrawal from pain, abnormal flexion, abnormal extension, and no response. The total score, including total components, it includes 15, and 8 or less than 8 is significant, and the least score would be 3. Let's say other tool, modified GCS, where you use it for a ventilator patients. So instead of verbal responses, we consider the Grimace response that includes the 5 components. 1, there is no response to the pain. 2, it is mild grimace or some change in the facial expression to pain. 3, vigorous grimace to pain. 4, less than usual spontaneous ability or no response to touch. And spontaneous normal facial activity or like coughs and everything, it is 5 response. So in a ventilated patient, instead of verbal response, we use a Grimace response. So it includes EG and M in a ventilator and EVM in a non-ventilator. So there is a modified GCS scale, Glasgow coma scale for infants and children that includes eye-opening, verbal response, and motor response. The components slightly differ from adult to the child and infants. There is another scoring called force score, which we use for responsiveness to monitor the responsiveness and document, but it's a bit complicated and very less often used in the ICUs. Coming to the next vitals, it is pain. In a critically ill patients in the ICU, the patients frequently experience acute pain. There are many factors that can lead to pain, including surgical and post-op traumatic wounds, prolonged immobilization, the use of invasive monitoring devices, and even routine nursing care like changing of dressings and positions also causes pain. Physiological response to pain includes increase in respiratory rate, heart rate, and blood pressure, increases patient's anxiety, sleep disturbances, which will affect the optimal recovery of the patient. Pain can incur functional limitations such as impaired mechanics of the pulmonary system and delayed ambulation, which could eventually lead to higher morbidity in critically ill patients. Tools for assessment in ICU. The numeric pain rating scale, the analog scale, the behavior scale, pain scale, and the critical care pain scales are the tools that we use to assess the pain score in ICUs. It depends upon different ICUs where we follow the protocol. A heightened sympathetic activity like hypertension, increased heart rate, and restlessness can be an indicator for pain in heavily sedated and paralyzed patients. Next vital is the urine output. Even though urine output is an indicator for renal perfusion, it is frequently used as an indicator for cardiac output also. 25% of cardiac output perfuses the kidneys. A drop in urine output may be the first clinical indicator of fluid and electrolyte imbalance and is considered as an early sign of hypovolemia. When cardiac output falls, so does the renal perfusion, ultimately leading to renal failure. The normal urine output in adults is 0.5 ml per kg per hour. There are conditions where the urine, they are addressed with regard based on the quantity of the urine, that is, anuria is considered to be less than 50 ml of urine in 24 hours. Oliguria, where it is less than 400 ml of urine in 24 hours. Polyuria is considered when it is more than 3000 ml of urine in 24 hours. And dysuria, which is painful micturition. There is a scoring tool which is called as Muse. It is a simple physiological score that allows in the quality and safety management of the patients. And basically, the primary purpose is to prevent the complications and prevent the delays in the interventions needed for the patients. It consists of 7 components of respiration, saturation, supplemental oxygen, blood pressure, heart rate, consciousness, and temperatures. It from 0 to 3, they are graded based on the each parameter. The grading is given, and according to this, we can act. Like from 0 to 2, it's continuous monitoring is needed, and from 3 you have to monitor if it is the scoring is 3, you have to collaborate with the charge nurses and monitor vitals very frequently, confirm it, and if there is an escalation to the score, you have to inform to the physician and restart, and following appropriate action plan should be taken. If it is 4, collaborate with the nurse, monitor the vitals every second hourly, confirm the Muse, monitor output, and inform the physician. If the Muse is 5, collaborate with the charge nurse, consider calling the 4RR team or physician starting in the hospitals, and inform the physician. And if it persists to be remains to be 5 for 3 consecutive readings, you have to shift the patient to the higher care level, where we can even discuss about the EOL based on the patient's clinical condition. And if it is more than 6, it is recommended to transfer to the higher level of care. Coming to some basic care given by the nurses in the ICU, that is, the first one is the oral care. The oral flora of a critically ill patient differs from that of a healthy individual and contains organisms that can rapidly cause pneumonia. Within 48 hours of admission, the composition of If the intubated patients does not receive effective comprehensive oral hygiene, the dental plaque and the hardened bacterial deposits develop on the teeth within 72 hours. This is followed by emerging gingivitis, gum inflammation, infection, and a subsequent shift from primary streptococcus and actinomyces species to increasing number of aerobic gram-negative bacilli. So, according to the different organizations and in the WAP criteria, that is to prevent the ventilator-associated pneumonia, comprehensive oral hygiene program is being indicated by most of the guidelines like CDC, APIC, IHA, and AACM. So, it is where the oral hygiene is very important in prevention of the WAP. So, the interventions are for all the hospitals. First, we should have a written protocol and training, initial assessment of the oral cavity of the pre-existing or the existing conditions. Dental plaque removal should be done with a soft toothbrush to brush teeth, tongue, and gums at least twice daily to remove the dental plaque. And toothpaste, we have to use toothpaste containing additives like sodium bicarbonate, which assist in the breakdown of mucosa and biofilm in the mouth. Antiseptic mouth rinses can be used, that is use of alcohol-free or hydrogen peroxide or chlorhexidine based rinses. They have shown to assist in cleaning the debris built up and provide antibacterial properties to prevent colonization and oropharyngeal cracks. Moisturizers, water-soluble moisturizers to assist in the maintenance of a healthy lips and gums at least once every 2 hours should be used. So recommend in the ventilated patients, assessment of oral cavity should be done, maintenance of saliva, oral tissue, health, and minimizing development of mucositis with all the cleaning criteria which has been discussed before, and head and along with that head and elevation to 30 degrees unless it is contraindicated, a subglottic suction should be done. According to Association of Critical Care Nurses, the oral cavity assessment and lips should be done every 8th hourly. They have to perform oral care every 2 to 4 hours and as needed, or perform oral hygiene using pediatric or adult soft toothbrush at least twice a day. Gently brush the patient's teeth to clean the removal plaque from the teeth. In addition to brushing twice daily, use oral swabs with 1.5% of hydrogen peroxide solution to clean the mouth every 2 to 4th hour. With each cleansing, we have to apply mouth moisturizer to the oral mucosa and lips to keep the tissue moist. Suctioning of the oral cavity and pharyngeal cavity should be done frequently and as indicated, whenever indicated. The next care that is given is the pressure sore care and the prevention of the pressure sore. Pressure sores are the area of damage to the skin and the underlying tissues caused by constant pressure or friction. The incidence of these ulcers in intensive care unit patients was found to be around 14.3% and they reported 63% mortality. The majority of pressure sores are of grade 1. The mean length of time of the pressure sore to develop was found to be around 10.4. A statistically significant difference was found in the patients for pressure ulcers development according to their level of consciousness, activity, cooperation, length of stay, and Waterloo scale score, and C-reactive protein levels. Complications of pressure sores, they are sepsis, cellulitis, bone and joint infections, abscess, and cancers. The risk factors for pressure sores, the factors that are influencing are the old age, immobility and paralysis, being restricted, impaired sensations, urinary and fecal incontinence, malnutrition, obesity, circulation disorders, smoking. And based on the amount of the mobility, restriction of the mobility and level of impairment, the sites of the pressure sores are differ from each person. So to prevent the pressure sores, the assessment should be done every 12th hourly. We have to do positioning changes, daily skin care, diet and lifestyle changes, and warning signs of pressure sores should be documented and watched closely. There is a tool called Braden scale, which is most validated and reliable in the risk of assessment of this. It includes 4 gradings, and for different parameters. The parameters include perception of the stimulus, where it ranges from 1 to 4 with totally inadequate, very adequate, a little adequate, or completely adequate. Like wetness, it ranges from 1 to 4. Activity, movement, nutrition, and friction and irritation that ranges from 1 to 3 grading. Based on the grading, the prediction of the risk for the pressure sore is done. If it is from 15 to 23, it is mild or no risk, and the patients with 13 to 14 are considered to be having moderate risk, and with 10 to 12 are high risk, and less than 9 would be considered to be having very high risk of developing a pressure sore. The pressure sore ulcer classification, it is done by 4 stages. The stage 1 category where the skin is intact with non-blanching redness of the localized area, usually over the bony prominence. In stage 2, the partial thickness loss of dermis presenting as a shallow open ulcer with a red pink wound bed. Or sometimes there would be like a small blister, ruptured blister or fluorocyclospin blister. Stage 3, full thickness tissue loss, subcutaneous fat may be visible, but bone and muscle and tendon are not visible. And stage 4, where the full thickness tissue loss with exposed bone, tendon, or muscle is seen. Slough or extra may also be present. And there are 2 other conditions where you can't stage it. One is the unstageable, unclassified, that is called the full thickness skin or tissue loss, depth unknown, where the full thickness tissue loss in which actual depth of the ulcer is completely obscured by slough or eschar in the wound bed. And suspected deep tissue, where the depth is unknown, is the purple or maroon localized area of discoloration, intact skin or blood-filled blister due to the damage of the underlying soft tissue from the pressure and or shear would be there. So these 2 are the unstageable and suspected deep tissue injuries. Rest of them are considered from stage 1 to stage 4. The treatment of the pressure sores, depending on the severity of the pressure sores, it depends. You have to do the regular positioning changes. Special mattresses and beds are used that reduces the pressures. Maintaining healthy diet and nutrition. Dressings to be kept the sore moist and the surrounding skin dry. Saline gauze dressings may be used if ointments or other dressings are unavailable. Light packing or any empty skin spaces with dressings to be helped to prevent infection. Regular cleaning with appropriate solutions can be done depending on the stage of the sore. There is no particular antiseptic or antibiotic that is superior to the other. Whatever according to your local protocol of your IC, you can go ahead with the solution. The specific drugs and chemicals applied to the area if an infection persists. Surgery to remove the damaged tissue that involves through thorough debridement of the wound, and operations to close the wound using skin grafts if necessary, and continuing the supportive lifestyle should be done for the prevention and treatment. Coming to the eye care given by the nurses, the ocular surface diseases, we have to do this because the ocular surface disease is common in ICU patients with 20 to 42% developing corneal epithelial defects. The surface is normally protected by the ability to produce tears, to blink, to close the eyes with rest or sleep. All of these mechanisms can be disrupted in the intensive care population, increasing the risk of developing ocular surface disease. The eyes are frequently, this is to be done by frequently assessing every 2 to 4 hours. In a ventilated patients, generally involves the regimen of cleaning the eyes every 2 to 4 hours with sterile water and installation of the liquid, moisturizing liquid, lubricating liquid. The ocular surface comprises the sclera and avascular cornea and conjunctival epithelium. And the diseases, it can involve any of these structures and can present as direct injury to the cornea, exposure keratopathy, chemosis, or microbial conjunctivitis or keratitis. So it is necessary for us to identify the diseases of the eye. The one is the first type of disease is like exposure keratopathy or corneal abrasion. The corneal abrasions are mostly accidental, which causes the redness, and it is best seen using a fluorescence dye, eye drops or blue light. And it is due to the incomplete exposure keratopathy causes the dryness of the cornea due to incomplete lid closure and excessive tear evaporation. It also manifests as a red eye. So it affects 20 to 42% of ICU patients, and 60% of those sedated for more than 48 hours develop epithelial defects. And as a result of prolonged epithelial defects can cause scarring or even in severe cases perforation of the cornea. Secondary infections can also occur. Treatment would be a simple corneal abrasion without secondary infection can be with chloramphenicol ointment 4 times a day for 5 to 7 days and increase lubrication and lid taping if there is significant unwanted corneal exposure. So grading of the exposure, you have to, there would be like 3 grades, 0, 1, 2, 3. Based on the grading, the action required would be taken. But if it is grade 0, no action would be there. Grade 1, you have to lubricate. Grade 2, you have to lubricate and take the eye. The other condition of the corneal disease is like chemosis. It is the conjunctival edema which causes conjunctiva to bulge out. The risk factors would be compromised venous return from the ocular structures. Maybe due that it would be due to some positive pressure ventilation, patients on high peak, or if it tight endotracheal tube tapings are done. And conditions associated with generalized edema, gravitational causes of increased hydrostatic pressure, like prolonged prone ventilation or recumbency, states that increase capillary leaks. Chemosis can cause impaired eyelid closure, while the impaired eyelid closure can cause chemosis. It's like a vice versa. Microbial infections in the eyes. The 77% of the ventilated medical patients are colonized by at least one abnormal bacteria species in 7 to 42 days. And multiple bacteria colonize up to 40% of those with prolonged ventilation and sedation. The most commonly associated organisms are Pseudomonas originus, Acinetobacter, and Staphylococcus. Respiratory secretions are the major source of ocular surface infections with aerosols from tracheal suctioning and direct contact of the catheters. They can be reduced if open tracheal suctioning can be done from the side of the patient or with the eyelids closed, or can be used with a closed suction. Conjunctivitis. ICU staff should always look for a sticky eye, which usually red. Conjunctivitis in the ICU setting is usually bacterial and can be very infectious and virulent. The management, it includes to take a swab for microbial culture. Discharge can be removed by bathing the eyelid with warm water using separate gauze for each eye. Chloramphenicol ointment is applied in the eye 4 times a day for 5 to 7 days. If the discharge and redness are not markedly improved based on the culture sensitivity, we can change the ointment used, antibiotics used, or if the cornea becomes dull or white, patches appear, we have to take an ophthalmologic consultation. Microbial keratitis. This is a condition where the damaged cornea is especially, which occurs in the damaged cornea, where it is especially vulnerable to bacterial invasion, which can occur very rapidly. It varies from superficial infection to deeper infection and can lead to permanent and severe damage and vision loss. Most cases are due to bacteria and appear as red eye, which may be watery or sticky with corneal ulcers. Sometimes viral could also be there, like herpes simplex keratitis, which also takes the form of typical dendritis in the corneal epithelium. If any of these problems are seen, we have to take an ophthalmologic suggestion. The other condition that we see commonly, not very commonly, is endogenous endophthalmitis. It is a rare and serious problem caused by spread of systemic infections in the bloodstream to the inside of the eye. The eye may be red, although sometimes much red than that might be expected. Endophthalmitis, it is to be suspected if there is a white line which is visible in the eye in front of the iris, which represents a level of pus in the anterior chamber. If this condition is present, immediate ophthalmic help is needed. There are few other problems that causes this. The severe or recurrent hypotension that causes the impairment of eyes, like severe recurrent hypotension can cause blindness from ischemic optic neuropathy, and in ventilated prone patients, increased intraocular pressure or intraorbital pressure with marked periocular swellings can decrease the ocular pressure, leading to ischemic optic neuropathy, central retinal artery occlusion, and can cause permanent visual losses. Rarely, those nursed in prone can also develop glaucoma due to the sudden increase in the pressure, intraocular pressures. In this condition, the cornea becomes cloudy and gray, and the pupils become fixed at mid-dilated position and in response to light. If these conditions are present, this needs to be immediate ophthalmic treatment needs to be taken. So these are the basic vital monitorings and the basic nursing cares of the eye care, oral care, and bedside cares that have been discussed here. I thank all the panel members for giving me this opportunity to share my inputs on this. Thank you, everyone.